right, we've all been there, right? That low serum phosphate pops up on the lab report, and suddenly you're staring at this massive, kind of daunting differential diagnosis. Well, this explainer is all about giving you a clear, systematic framework to just cut right through that noise. By the end, you'll have a super efficient pathway for even the trickiest cases of hypophosphatemia.
So the lab result is in. Your patient's phosphate is low. What do? What's your next move? Getting to the right diagnosis in the most efficient way really just comes down to having a structured game plan. So let's build that game plan right now.
Okay, so before we can even think about interpreting those labs correctly, we've got to make sure we're all on the same page with the key players, the hormones that basically run the whole phosphate show. They are the absolute foundation of our entire diagnostic algorithm. You can think of phosphate balance as this intricate dance between three main partners. You've got the gut, which is all about absorption. Then there's bone, kind of the big storage unit. And finally, the kidneys, which handle getting rid of any excess. And the ones calling the shots, the ones conducting this whole orchestra, that's our small group of key hormones. The first one you absolutely have to know is fibroblast growth factor 23, or FGF23. It comes from the bone, and its main job, really its one job, is to tell the kidneys to waste phosphate. Just get rid of it. That makes it our master phosphatoric hormone. And honestly, it's our #1 suspect anytime we're thinking about renal phosphate loss. But of course, FGF23 isn't a solo act. Parathyroid hormone, PTH, also gets in on the action and promotes phosphate excretion from the kidneys. And then, counterbalancing all that, you have active vitamin D. That's 1,25-dihydroxyvitamin D, which cranks up phosphate absorption in the gut. It's this constant push and pull, this tug of war, that keeps everything in balance. All right, with those key hormones in our back pocket, we get to the first, and I mean the most critical diagnostic step. We have to figure out where the phosphate is going. The central question is simple. Are the kidneys messing up and wasting it, or is the problem coming from somewhere else entirely? And the tool for that job is the TMP/GFR. It's a pretty straightforward calculation. You just need serum and urine phosphate and creatinine. But it tells you exactly what you need to know about how the kidneys are handling phosphate. Are they holding on to it like they should be, or are they just letting it leak out? This single value, this is our first major fork in the road. And what's so powerful about this one test is how cleanly it splits our differential diagnosis in two. It's beautiful, really. If that TMP/GFR is low, boom, you've confirmed renal phosphate wasting. Your investigation now zooms in on the kidney. But if the TMP/GFR is normal, well, that tells you the kidneys are innocent. They're doing exactly what they should be doing. So we know we have to look somewhere else. Now let's walk down each of these paths. Okay, let's head down pathway A first. Our patient has a low phosphate, and we've just confirmed they have a low TMP/GFR. So the kidneys are definitely wasting it. The next logical question is, why? What's driving this? And this brings us to our next crucial question. We need to find the culprit. Is it being driven by that master phosphatoric hormone we just talked about, FGF23? Answering this one question is going to dramatically slash our list of possibilities. If the answer is yes, if FGF23 is the problem, our differential immediately shrinks to a very specific group of disorders. We're talking about things like the inherited condition X-linked hypophosphatemia, or XLH, and acquired causes like tumor-induced osteomalacia, TIO, or even some cases of fibrous dysplasia. And the key to unlocking this part of the puzzle is simply measuring the serum FGF23 level. So let's look at a classic lab pattern here. Of course, it starts with a low serum phosphate. Then you see the low TMP/GFR, which confirms, yep, the kidneys are wasting it. And then here's the clincher. The FGF23 level is high. Now, you got to remember this key point. Even a normal FGF23 level is completely inappropriate when phosphate is low. It should be suppressed to near zero. So when you see this triad of findings, you are looking right at an FGF23-mediated process, like XLH. Okay, let's switch gears and jump over to pathway B. What happens if your patient's phosphate is low, but their TMP/GFR comes back normal? This is a huge finding. It means the kidneys are off the hook.
They're actually doing their job perfectly, trying to hold on to every last bit of phosphate. So the problem has to be coming from somewhere else. It has to be extrarenal.
So where else do we look? Well, the extrarenal causes really fall into three big buckets. First is the patient just not getting enough in their diet. Simple, inadequate intake. Second, could there be a malabsorption issue from something like celiac disease or maybe a history of bariatric surgery? And third, could it be a transcellular shift where phosphate is just moving out of the blood and into the cells? Of course, refeeding syndrome is the classic example we all think of here.
And here's what the labs might look like in this scenario. You've got the low phosphate, sure, but look, the TMP/GFR is normal. That is the key finding. That confirms the kidneys are responding appropriately. And then you might see other clues, right? Maybe their 25-hydroxyvitamin D is low, which could point you towards a nutritional problem. The whole picture here just screams intake or absorption issue, not renal wasting.
Okay, so we've gone over the basic physiology and we've walked down the two main diagnostic pathways. Now, let's just synthesize all of this and put it all together into one single practical framework that you can actually use in the clinic with your next patient.
Here is the whole thing distilled into 4 straightforward steps. Step 1, just confirm it's a true hypophosphatemia and get a feel for the clinical context. Step 2, calculate the TMP/GFR. This is your critical branch point, that big fork in the road. Step 3, if that TMP/GFR is low, your next move is to measure serum FGF23 to see if you're dealing with a phosphatoric hormone excess. And step 4, if the TMP/GFR is normal, that's your cue to start digging into those extrarenal causes, poor intake, malabsorption, or a cellular shift. That's it. That's the systematic approach.
So I'll leave you with this thought to chew on. We're now in an era with these incredible targeted therapies, things like FGF23 antibodies. It really changes the game. It's not enough anymore to just say this patient has low phosphate. We have to know why. So the question becomes, as these treatments get even better, just how critical will a precise etiologic diagnosis be for truly optimizing our patients' outcomes?